So, we're going to talk about shoulder pain and a holistic approach to it. It starts with just a case that doesn't always go that well, and it can be the day you walk into office and the patient tells you, hey, your injection failed. No one really wants to hear that, but here we have a 53-year-old male with adhesive capsulitis, and it's 3 months from the first visit. So this person came to you, they had really bad pain, 100%. You did a suprascapular nerve block, and you gave him home exercise, and the pain came down to 40%, but it's not fully gone. And if it's not gone now, this person defaults on exercise, and they assume that you failed them. There's details we tend to overlook when we look at shoulder case, and that would be things like obesity, diabetes, way back posture. But what we want to get at too is why did we fail? If at all, did we fail? There's two approaches to shoulder. One is traditional approach, look for something to label, treat the label. The other one is population, and this is a population-based medicine approach. The other is a holistic approach where you look at local factors, global factors, biochemical factors, lifestyle, and psychosocial factors that can lead to what manifests as a shoulder pain, because it might actually be more than that. This is more personalized care. It's actually what most people seek when they come to us. It's just they don't know they're seeking it. The traditional approach is what we all know. You got a history where there's pain, there's difficulty with upper extremity activities of daily living, and the exam shows you a painful, restricted shoulder with restricted range of movement. And you can do some lab work for the acute phase reactants are maybe elevated, maybe not. There might be a high A1C depending on if they're diabetic. Usually with the adhesive capsulitis, the x-rays will be negative. The MRIs might show you some capsule thickening. We make a diagnosis, periarthritis shoulder, and from there we can look at treatment, and treatment will be by the evidence-based guidelines, and then from there, whatever skills and biases the clinician that's treating has. That's the traditional approach that we all know. But what we're overlooking when we do this is we're overlooking that muscles are connected via joints, and that muscles that don't behave normally end up making problems. So if a muscle is overly loose on one side, the joint might start turning towards the normal muscle. If a muscle is abnormally tight, again, the joint might start turning towards that muscle, meaning deformation or restricted active and passive range of movement. When both these things are happening at the same time, you have a whole new problem, and the joint can be really, really deformed or just not working properly. It's more than that, though. We want to look at these muscles and joints and turn them into levers. So we know a class 1 lever. It's our standard lever where the force is on one side, weights on the other side, fulcrum in the middle. Class 2 and class 3 levers have the fulcrum on one end and varieties of load and force in different positions. But when we translate this into the shoulder as a joint, you can see the shoulder has forces pulling in both directions. So in the anterior plane, you could have a pectoralis major pulling it, and a coracobrachialis. And in the posterior plane, you could have latissimus dorsi or posterior deltoid pulling it backward. And this is essentially a glenohumeral joint. But it's much, much more than that, you see. There's not just one joint floating around in space. It's connected to other joints through these muscles. And look at that. There's a sternoclavicular joint proximal to it. There's a humeral ulnar joint distal to it. There's a radial ulnar joint separate to that. And all of them have different muscles acting on them at the same time. Meaning if you have dysfunction in the glenohumeral joint, if we don't check the proximal joints, we have a problem. Now, there's very common dysfunction patterns that emerge when a person has a shoulder dysfunction. Proximally, we find that the trapezius, levator, scapula, sternocleidomastoid will be very tight, meaning the sternoclavicular joint may not be that free to move. The glenohumeral joint, it can have a tight pectoralis major, coracobrachialis, and possibly even an overstretched latissimus dorsi or posterior deltoid. The humeral ulnar joint can have a normal biceps but an overstretched triceps, what we see as little wingdings hanging off the arm when a person gets their arm up. And then the distal muscles supinator teres FCR, supinator ECRLB, and ECU, they are actually going to be normal. But we have to look at the levers again. So here's a standard class 1 lever, but the rest are all class 3 levers. And these levers now determine how things start to fall into place. We're simplifying it. We have a pattern of proximal tension, intermediate, overstretched muscles to compensate for that tightness, and distal muscles that are relatively normal. And then we superimpose that onto an arm. Now you can see how things go. So this is kind of what we're dealing with on a daily basis when we see a person with a shoulder pain. And what that means is just treating the shoulder alone is never enough. Now, what is that? What you've seen is a myofascial chain. It's a set of muscles that are linked together through their investing fascia and origin, insertion, and function. And when you look at this, there's 4 different chains that are acting directly in the upper extremity, the superficial and deep anterior, the superficial and deep posterior chains. We're going to look at those in depth now because these chains actually determine a lot of what we see clinically. And if we don't treat them properly, we're not going to get the right outcome. So anterior chains are prone to shorten, and the muscles that compose them will be things like an anterior deltoid, a pectoralis major, the serratus anterior, the core muscles like external oblique. The deep anterior chain would have upper trapezius involved, pectoralis minor, biceps, muscles like that. So these form the superficial anterior chain and the deep anterior chain. But then we have the posterior chains that are prone to get overstretched just because we tend to have our head facing forward a lot. So here you have posterior deltoid, you have triceps, there's infraspinatus, teres major, the rhomboids, the middle trapezius, and that all forms a superficial posterior chain. And then there's a deep posterior chain that has upper trapezius, levator scapulae, infraspinatus, teres minor. All these different things tend to come into these different chains. And these chains, when they go into dysfunction, determine how the shoulder problem evolves. When a muscle is in dysfunction, it has a particular set of clinical features. The first is tender points where it hurts, but there's no fibrofatty nodule. The myofascial trigger point, a fibrofatty nodule with or without pain. Myofascial trigger points that radiate along a particular pattern. So the trigger point now traps the artery nerve in the fascia and causes pain to radiate around. Or sometimes you get a click, pop, or grind outside of the joint. All these things are the ways muscles dysfunction. If we don't know which muscles to check, we're going to miss the bigger picture. So we have to connect all of this together. And it's not just that there's chains floating around in an arm in space. It actually connects into the trunk, the core of the body. How? First, we have to think about general posture. So we mentioned at the very beginning this man has a sway back posture, which is characterized by a forward head, an excessive thoracic kyphosis, and loss of a lordosis in the lumbar region. Typically, this is going to be overstretched interscapular muscles, and then an overstretched iliopsoas. You can see all the patterns here. But from there, you can see the normal spinal pattern on the left and the sway back on the right. Now that excessive bulge in the thoracic region with a compromise in the anterior abdominal wall means the muscles that normally hold the scapula in place are overstretched and compromised, and the scapula migrates upward and forward in that direction, pulled by unopposed action from pectoralis major, coracobrachialis, because middle trapezius, rhomboids, latissimus dorsi are not working as well. So you get holistic connectivity, and this is how we have to connect these things into the chains that govern the arm actions. So when we look at the anterior chains, we have pectoralis major and serratus anterior that connect to the external oblique and rectus abdominis. We have biceps brachii and iliopsoas that connect to rectus femoris. We have serratus anterior connected to the adductor longus and gracilis. We have subscapularis connecting the transverse abdominis and the pelvic floor. The deep cervical flexors connect to the diaphragm and the psoas. We have the obliques linked to the adductors and the shoulder rotators. And we have latissimus dorsi connecting to the contralateral gluteus maximus, trapezius, rhomboids, erector spinae, and hamstrings. We have posterior deltoid and triceps linking to the glutes and the hamstrings. And then we have the spine extensors linking into the hamstrings, gluteus, and erector spinae. We have rotator cuff linking to multifidus and erector spinae. We have lower trapezius and gluteus medius and TFL all linked together. We have scapular retractors and the peronei. When we see all these things, one wonders what's the value in learning all these connections. But it's for us to learn to put these things together so we can better treat a person. Now, that's one whole aspect to care. And it's a very important part of care because if we can't address muscle imbalances, we're not going to get people better. But we have to look at it a little bit more here. So this is what you see as age proteins, advanced glycation end products that independently float around in circulation and cause inflammation on their own. These can deposit in tendons, capsules, joints, muscles, even the inside of a blood vessel, but it causes inflammation. The other thing is lifestyle. What kind of diet does this person consume? So, are they on a high carbohydrate, high fat, high salt, sugar diet with lots of preservatives, all in the wrong ratios, and low micronutrients? That's actually a very normal diet nowadays, the multinational corporation diet. It's not good for people, but it's good for the rich people who want to become more rich. And the assumption is it tastes good, so it must be good. But actually, we don't need that much carbohydrates, and most of our plant-based carbohydrate sources actually are also the best sources are going to be proteins, like a lentil. We don't need much more fat than we already have. And then from there, salt and sugar really don't help the body heal. Preservatives often cause inflammation, and the right ratio would be half of the daily intake will be plants, 1/4 carbohydrates, 1/4 plant-based proteins. The next is a psychosocial approach, and we have to really think what behaviors and use patterns lead to the local and global findings. More and more nowadays, we find people bent over a small screen staring at it with their head forward and their entire spinal curvature deformed because they're focusing on something that is often 30 seconds to a minute of just complete nonsense, things that are not really relevant to their life or them becoming a better person. But these blue light emitting devices can affect sleep. We have to also check for addictive substance use, the amount of physical activity they have, and from there how they manage their stress. And you'll find the more and more of these modern gimmicks we have, the less and less we have of our basic needs being met. People won't sleep well, they won't get physical activity, they won't manage stress properly. In fact, many of these things trigger people to get overactive. The question people ask me is, see, you took shoulder, such an easy thing, that's an easy source of money and just a quick case, and you made it so complicated. Why should I learn all this? The day you know someone personally who's suffering, you don't want to treat them as a commodity to be injected and sent off to a therapist. You want to deeply understand why things are happening the way they do. And if you treat everybody that way, your patients will come to love you. So, if that's the case, then how do you begin to learn all this? Look for a deeper history and exam. Now, many people that come with shoulder pain don't want to talk about their back pain or their neck pain or their leg pain, but it could be happening at the same time. And getting a deep history helps you understand what is and isn't, such that the next time those things come around, you're better equipped to deal with them. If you can examine the muscles along the myofascial chains, you have all the information here, then you know where to check, and you know what to check for. So when you start finding indicators of muscle dysfunction somewhere outside the shoulder, you now know what chain you're dealing with and how it should be addressed through what exercise at what time. The other thing is looking for other painful areas that these people have, and then looking for signs of muscle imbalance across joints. The majority of people you meet that have a shoulder dysfunction, that come with things like a periarthritis shoulder will typically have an anterior shoulder that is adducted and pulled over the thoracic cavity. And when you see these deformities over and over again, you'll understand what muscles are underlying that problem. But the real thing is, the eyes see what the mind knows. So if you don't know these things, you can't help people.